Hi, thank you for joining. Today, I'd like to do something that I wanted to do for a very long time and just waiting for the right opportunity, the right time, the right case. Hopefully this is one of such cases as probably dural fistulas are. And what I'd like to do is go through this one case. And this case is our grain of sand. We see a world in a grain of sand. The grain of sand is the case. And the world is our world of neurointerventional radiology, the anatomy, the intervention, the philosophy behind our treatments. And much of this can be gleaned from an analysis of this case alone. This is a particularly useful technique, perhaps underutilized, and certainly something that I've used in my learning. And I think we're going to use that today. So it'll take some time. So just budget a little bit or come back. I'd like to dedicate this page and the session to three people. First and foremost is my mentor and teacher, Dr. Peter Kim Nelson. When I joined Kim's fellowship, since this was kind of an enfolded thing, and internship and residency, from the very beginning of my training, what would happen is we would come in on Thursday afternoons, a bunch of us would sit down, someone would hang cut film on a roller, and we would analyze a case. Kim would have us analyze a single case. Often it was a dural fistula case. And in that case, using this method, this is a method that he used very often. In that case, I would see an entire world of what we do. And it was amazing. It was one of the most incredible teaching experiences I've consistently had. And we want to pass that on. So, this is dedicated first and foremost to Kim Nelson. Also dedicated to Eitan Raz. Eitan is my closest colleague and friend. This is his case. He picked the strategy, analyzed it, dissected it, stuck to the strategy and succeeded in like really nice way. And in many ways, not just in this case, but in many cases, many instances, Eitan, his genius is behind much of what goes on in neuroangio, and so this is really important and it's dedicated to him. And finally, of course, it's dedicated to William Blake. Now, William Blake, you are not familiar, you can go back up here, read some of his poetry. Please do, it's beautiful. And as many people of his age were, he wasn't just a poet, he was also an artist. A lot of his art is has some biblical motifs. This is one of his works that has to do with like Chaucer's Canterbury Tales. Anyway, so here we go. Basically, our case is a cavernous sinus fistula. Look at this MRI. This is how they start off. You see some abnormal signal, a little bit of what looks like a flow void in the right cavernous sinus. So that, of course, takes us to the cavernous sinus, part of the world in a grain of sand. We start off as a cavernous sinus page. This page has taken a lot of time to put together. Some amazing pictures there. A lot of them are done by Eitan Raz again. And it's not just art. It's not just beautiful pictures, which I think our field is a lot of it is art. But it's a ton of anatomy. It's like great stuff. So if you have time, study this page. There's a lot on this page. Now, when we look at this post-contrast T1, we're going to see something interesting. As we not infrequently see, we see some of these veins. You see these transmedullary veins that are somehow participating in something involved in this fistula that we will see later. And so that takes us to the transmedullary veins page. This page itself is not just dedicated to Yunpeng Wang, who was one of the visionary neuroradiologists, one of the first worked, most of his time was spent at Sinai, where he developed both techniques and developed a really like pioneering understanding of particularly venous system that I think remains unparalleled. His works, if you look up his books, his descriptions, his pictures of venous system, I think they're still unsurpassed. Him and a number of his Japanese colleagues have worked on both angiography, early angiography, and also various ex vivo methods to define much of what we understand today about the venous system, particularly about the transmedullary veins, these deep veins that traverse the white matter. You can see them here. So here's a medullary venous malformation page. He called it a medullary venous malformation, what we know today as a developmental venous anomaly or DVA. But essentially, it's the same thing. And it's really him who defined it. His name didn't stick. But this is what it was. It's these beautiful pictures. These are some like ex vivo embryo stuff. Some of his understanding, like basically going into the details of what these veins are and how they're related to the formation of DVAs. What we now know is DVAs. There's some beautiful work here. Here's a 7 Tesla MRI, by the way, so we can see these things very well in MR now, and on Dyna, they're beautiful as well. See these veins. This is amazing pictures. This is his collection. It's a life's work of Yunpeng Wang and his collaborators, which you can see below. He graciously donated this slide collection to a neuroangio. Some of them have been digitized, and so you can see, you can go here and you can see some beautiful work. And so this can go on. You can read into this. You can understand a lot about developmental venous anomalies, superficial drainage, venous drainage, these kinds of ideas. A lot of it starts to make a lot of sense once you look at Yunpeng's work. So, so that's that. Now, apart from that, it's also important and emphasized in the website is the balance, as everything is, so many things are in balance. We emphasize balance all the time, but there's a balance in venous everything. There's a balance between tralard and labae and superficial veins and whatever. There's also a balance, normal physiologic balance between superficial and deep venous systems, which you can see on the deep venous system page. I'm not going to go through here, but the idea being that in some people, the medullary veins might preferentially drain deep, and somebody else, they might preferentially drain superficially, and that can be influenced or reflected in sizes of, say, the superior sagittal sinus. People with hypoplastic superior sagittal sinuses that tend to drain deep in a very non-pathologic manner, and vice versa. So I think that's also important. And so that takes us to that page, but now we go back. We look at some of these 2D post T1s, which are a little bit better. See, like you can see much better actually than on a volumetric sequence, both this abnormal cavernous sinus and these abnormal veins. So there is something to be said about like MR techniques here as well. We won't go into that too much. Right here, they're highlighted for those that are reading the page. Okay, now we go into the angiogram. Fortunately, this page has stayed a little bit small, but bottom line is that we're doing an angiogram. Now there's a whole art to how we do angiography. You look at this injection, the fistula is on the right, of course, the injection's on the left, and you can see supply from the left to the right of these vessels. Now these vessels, we're not gonna hold this as a puzzle, we'll just give you the answers here for most of this. And so the supply here is gonna come from the contralateral ascending pharyngeal artery and from the contralateral meningohypophyseal trunk. And as you can see, there's a whole bunch of vessels converging on the cavernous sinus on the right, which of course takes us to the ascending pharyngeal artery page. Now that page can take a while to load because there's a lot on it. So sit back for a second. There's a lot of overview here. Please take a look. There's a lot of information on this page. That's also taken a while to collect. Particularly important, I would like to emphasize, again, the balance. The whole balance and the whole notion of these classical ideas of, the ascending pharyngeal artery, neuromeningeal trunk, pharyngeal trunk, fine, that's all great. And it's important to know that. But the reality is very, very more divergent than you might think from these classical teachings. The bottom line is that anything is possible. We've looked into this, and the more you look, the more you see, of course. You see that the neuromeningeal trunk can originate from the occipital artery, aside from the, this whole pharyngo-occipital variant, individually, not individually, hypoglossal, jugular. You're going to see that the only way to really know where anything is coming from is probably to either be like a genius at looking at 2D images, or to do a Dyna or VESA or some kind of like a flat panel CT, which I think is really what it takes, because until we had flat panel CT, the geniuses, I think, under-recognized this themselves. Basically, this is like a little plug for looking at things with open eyes and understanding that there's a balance in everything. And of course, the ascending pharyngeal artery is a very important artery that, that we should be aware of. Now, okay, MHT, we won't spend too much time on these pages. You get the idea. You study the page. Now, I do want to emphasize one thing. There's a new set of diagrams, relatively new. We did this in 2020. Had some time on our hands, and among other things, we were doing this. So this is a new set of diagrams that we have. Now, these diagrams are actually a key. They're part of a diagrams and drawings page. So if you go to a diagrams and drawings page, I don't want to go there now because we'll lose our we'll lose this page if we do that. But if you go to the diagrams and drawings page, on that page, there'll be links to a whole bunch of vessels that are not on the main page. There's all these little vessels like artery of the foramen rotundum, the, artery of the, whatever, the tiny little arteries, amongst many other arteries, facial, lingual, all these other things. So there's much more on the website than meets the eye at first. And if you go to the diagrams and drawings page, you'll see it over there. So on we go. So here is an injection of the left ICA. You see better these contributions from the contralateral and the hypophyseal trunk along the back of the clivus coming into the cavernous sinus, and you see some drainage here. So now we're starting to understand the drainage of this lesion. It looks like the drainage is really confined to the sylvian system. Doesn't look like there's much there. Don't see no petrosal sinus, don't see an ophthalmic vein. So that, of course, becomes important. Here's the dedicated external injection. And we see a myriad of tributaries from the mainly the pharyngeal division of the ascending pharyngeal artery to the back of the cavernous sinus again. Now, this is a whole other world of cavernous sinus dural fistulas and the classical anatomy of those. The most common location of a fistula, common venous shunting pouch, we'll get into that, or the tributaries, all the vessels converge way most of the time, over 75% of the time, on the back of the cavernous sinus. That's where most of them are going to be. So is this one. Now, the venous drainage, as you can see, is obviously challenging. It's all like reflexing into the cortical veins via the superficial, by the sylvian veins, and you don't see ophthalmic vein drainage. You don't see a petrosal sinus. There's a little bit of it like here, but it's indirect. And so obviously, I'm starting to think, if you've been doing this for a long time, I'm sure you know a lot of this, and you're wondering like what exactly to do and how to get to it. Now, the other important point here that we want to emphasize, and again, it's something that I think is like very, very crucial to understanding vascular anatomy, is that when we go back to these pictures, like these diagrams and drawings, and you see these lines that we draw, like a line for, the cavernous branch of the MMA, the line for the petrous branch of the MMA, these lines are really just primitive, simplifications of what the world is. The world, again, like you see a world in a grain of sand. Right here, you see, look at all these vessels, like all of these vessels, they're mostly, a lot of them are unnamed. You can think of them as, okay, you're going to say, well, maybe some of them are going to be part of a network. But these are unnamed vessels. They're mostly, they're transosseous, the vast majority of them. You could say, well, maybe they're part of the carotid system or whatever. But the reality is that there's myriads of them, and they're just, amplified. They're amplified by flow demand of the shunt. And this is how it is. Like oftentimes it's what we see is just what we see. We see one vessel, maybe we don't see anything because our vision is limited. But when pathology expands physiology, these vessels become, larger through hyperplasia, hypertrophy. It's mostly hypertrophy in this case. But when you look at this, you realize how complex things are, and that you really have to think in terms of networks and in terms of balances and spectra when it comes to anatomy. So you see all of these vessels. Now, the importance of these vessels is that they can be used for transarterial intervention. If you're going to pick, probably if you're going to pick one safest way to hit this, you'd wedge into one of those and try to pour some glue into this pouch. That's probably what we would do if we had to choose a transarterial approach. That would be the least unsafe approach that there is to a transarterial embo of these things, because obviously it's a little bit involved, lots of connections. So, okay. Now, like I said, we're taking our time, going through this slowly. We love stereo, cross-eye stereo. If you know how to cross your eyes, right image and left image and right, you can see this in stereo. A lot of the stereo has been supplanted by Dyna or flat panel, methodologies. But those things take time, so they're less dynamic. So if you want to, there's still, despite the development of these sort of flow or time, time-sensitive dynas, particularly in AVM evaluation, there's still a lot of, we use stereo a lot. And that takes us to the stereos page. Now there's a whole page here dedicated to stereo angiography. It is a form of art. Again, we like to consider this as partly art, which it is. And so there's explanations of how this works. There's a whole world of stereo photography out there, as you know, 3D movies, whatever. Read this to find out how to take stereo pictures on your phone, and more germanely to what we do, find out how to take stereo pictures of our images, which is basically like this. Now, once you collect them, combine them, there's different ways of doing it. You can see them as cross-eye, you can see them as anaglyphs. So we have here, we use these glasses in our banana course. So buy these, they're literally still a dime a dozen, even today. The paper, they work great. You can see anaglyph images if you're having trouble with cross-eye stereo. But it's a great tool, and I think a little bit underutilized in our field. Okay, so having talked about stereo, we talked about anaglyph stereo. This is an anaglyph. You can see like a red-blue shadow here, and it says anaglyph down here also. You need those glasses to see the 3D in here. Okay, now, one more. This takes us to the Dyna. So of course, we've, as you know, recently, and we've been particularly interested in taking flat panel imaging to as much as we can take it to, and it's yielded some amazing results for us, particularly in visualizing some great structures like the central retinal artery and other, middle meningeal, arterial, venous networks. All of this stuff is amazing. Given modern Dyna capabilities, which are also, only going to grow. And we're, we really like to squeeze as much out of that stuff as we can. And so you can do this. Look, take a look at this. It's a video of a left common injection, the same one that we saw. You can study that. You can, so if you're doing this neuroangio, you can pause it, you can make it big. And you can scroll through the individual images like that. And you can see a whole bunch of anatomy. You can see all of these vessels right here. Go back a little bit. Grab that. Go back. You're going to see all of those ascending pharyngeal branches. This transosseous network right here. And so all of that is going to be reflected in these dynas. Now, okay, fine. So we go to the right, right side. This is right ECA. Here we are into the middle meningeal network. I think we've done some very important work in intrinsic vessels of the MMA recently. But you can see again, this is like a spectrum. Look at all these vessels. Like there's not one artery, a foramen rotundum. There's like a whole network of rotundum arteries that you can see over here. The same thing about the cavernous branch, like the cavernous branch. Okay, let's go there for a second. Cavernous branch of the middle meningeal artery from the skull base, as soon as the middle meningeal artery gets into the head, usually gives off this medially projecting branch that anastomosis with the cavern, with the meningeal branch of the ILT. Right here it is. On this diagram is this again, like it's just like one spindly vessel. The reality is it's a whole network, right? So here, this is like an MMA embolization case. And so in the case like this, it's, it's not, there's not a shunt. So you basically just see like really nicely, see right here is your cavernous branch heading towards the Meckel cave. And so obviously the clinical significance of this is if you hit that branch with a liquid embolic, you might take out some Meckel cave nerves with that. So be careful. That's one of the 3 reasons, at least, that primary MMA, that proximal MMA embo is a bad idea. You got the cavernous branch here, which not too many people talk about. You obviously have this petrous branch here that more or less everybody knows about. You go back there, you're going to take out the petrosal nerve and the facial, potentially, if you're particularly unlucky. And then, of course, there's the ophthalmic connections with the MMA and the orbit that we will not belabor. Okay, so this is a little glimpse into the middle meningeal artery page and even into this like little specific artery called the cavernous branch. Again, we see like all of this tons of supply. Now you're starting to see, again, everything is coming into this spot over here in the back of the cavernous sinus. Okay, so this is an occipital artery injection, and you see, guess what? Remember, we talked about the ascending pharyngeal artery, how everything is a spectrum and things can come from wherever. Look at this. This is a right occipital injection. You see this branch here. This branch happens to be the jugular branch of the neuromeningeal trunk normally, but this is just, again, isolated. Jugular happens to come from just occipital alone. Everything else is coming from the ascending pharyngeal proper, but this one, loner, comes this way. Again, this is the ascending, this is the clival network, posterior net in the posterior of the clivus, coming up into the back of the cavernous sinus. So again, like if you don't know what this branch is, stick a catheter into it proximally, you might take out the nerves that go through the jugular foramen. But as it happens to be, if you can use something small, I'm not sure if that would work here, it really breaks up here, but if you can get beyond the foramen somewhere like wedge somewhere in the clivus, I think pouring some glue from here is also not a terrible idea, and it just tends to flow. Kim Nelson, I've seen him do this like a bunch of times. You just like the stuff from here just flows. So wedge, use the glue, it just for some reason it just tends to go. You can put a lot of glue into this pouch, but of course it's transarterial, so all of these MHT, carotid, whatever, there's no end of anastomoses there to make your, make it a serious undertaking. Okay, so now we finished, we can talk about the arterial supply forever. But having done all of this, you can see that if you look at the left ECA and right ECA injections, of course, you've probably noticed by now that everything is coming into this pouch. And this is important. All of these myriad arteries, a tremendous amount of arterial supply, everything is coming into this pouch. So this is something that we really emphasize a ton. And we'll get back to that a little bit later, actually. Because what's important now that we've understood the supply of the fistula and all of this minutiae anatomy, what's really important in terms of the patient's physiology, right, is what is the brain doing? It's always important to understand how the brain is draining. That's key. Dural fistulas are, the pathology of dural fistula is venous, right? They pretty much never rupture. All of their pathology has to do with venous congestion. That's why the Coignard and the Borden classifications are enduring, because they tie the disease to the clinical manifestations and the risk of hemorrhage and all these other things. So when you look at the injection of the right ICA, you notice that there's not too much supply to this fistula from the right ICA itself. You might think like, hey, this is going to be the biggest source of supply. The thing is right there. No, of course, it doesn't have to be the case. Why? Because again, things are varied. So in this particular person, for example, the cavernous branch was providing a lot of the supply to the ILT area, which is why the ILT in this injection is not doing too much. Why? Because the cavernous branch, he was born that way. The guy's cavernous branch was always like dominant in Meckel cave supply, and so it picked it up. And so here it's a little bit less. But of course, this allows us to see what the venous drainage is. And look at this. It's a very interesting thing. When you look at this venous drainage, look, this is like a parenchymal plate, whatever, parenchymal phase. And when you see the venous phase, look at what you're starting to see. Look at all of these veins. You see these transmedullary veins coming into the tributaries of the internal cerebral vein and thalamus striate system. Right? You go back to the MRI. Now you understand what all those things are. They're basically normal. These are normal. This is normal brain drainage, right? The drainage is not the fistula that's taken over these veins. The fistula is busy like taking over the cortex. So what happens here? There's a shift of balance, right? There's a balance between superficial and deep drainage. What happens? The fistula takes over the sylvian system, starts going here and there. Where's the cortex going to drain? The cortex is going to shift drainage wherever it can. In this particular case, it shifts deep. And so you see these veins are accentuated by whatever blood is trying to get in there. The lateral is a little bit, less obvious, but you see all these dots here, like you're basically looking like down the barrel of these transmedullary veins. And so you see these like dotty things here. So some of them are up here, some of them are down in the temporal lobe. If you go back to the MRI, you saw them both, up above here and down below here. So again, this is very important. We emphasize putting everything together. So now you put the anatomy together in the physiology, and this is beautiful. Right here is a cross-eye stereo pair. Again, like if you see this in stereo, it's just breathtaking. It's like these pictures are just awesome. If we may say so ourselves, but it is great. So we did some of that. Now again, here's a Dyna injection. Now this Dyna injection is important. So we're going to pause on that. A key. I made it a little big. And so now, okay, so here's again, we saw that. You remember that post T1 2D MRI? You saw that over there. Now, what are we going to do? The question finally, like if you're just wondering like, okay, let's get to the treatment. This is not the purpose of this talk. Just to talk about treatment. But now we come to treatment. How do we treat this? Transarterial, transvenous, the usual like possibilities. We talked about the transarterial ones already, because we spoke about the arteries. Now the veins. How do we get to this? The fistula is back here. We don't see a petrosal sinus. We don't see an ophthalmic vein. We don't see anything else that's like connected to whatever, to however we can get to it. Now, often when there is no petrosal sinus or whatever, we can do a direct transorbital approach. So we do emphasize that. That's not a new thing. The transorbital approach has been around for a long, long time. You could see there's like there are some references below that are quite like, it's underutilized. Let's put it this way. It's underutilized. Obviously, it involves like identifying essentially what it involves. And there's a type, we have a video published, so you can see like there's a link to our video. And there's information, I'm sure, if you want to learn about how to do it. what angles to pick and whatever. You can see the technical details, but the bottom line is that you have to have, we try to put a needle into, like we use a needle, others use like an angiogram, like a more like a, you know, they try to, you want to use like a, something like a micropuncture or microsheath, but we just put a, like a Seldinger-esque kind of needle. At the superior orbital fissure, we're aiming towards this spot over here. And that's the way to get in there. And of course, it looks a little bit dramatic, but actually, so far in our experience, it's been safe and very, very effective. It's a quick way to get in there, and it's relatively consistent. So I think something that we also emphasize. It looks like that, right? Looks like this. And then when you do an injection, you see what you see like this. And then here it is with a bunch of coils in there, right? So take a look at that. We have a couple of other pages, and we got, this is our video here. Now, the problem with this approach here is that we don't see a connection between here and the superior orbital fissure over here. So that, in this particular case, just didn't seem very promising. I don't know, you'd have to like continue like sticking this needle back here, and it wasn't really clear how that would go. So we figured, I don't know about that. Now, so that's the magnified view showing the same thing. Okay. Now, the other option, and that's really the option that ultimately worked, is an access via the occluded inferior petrosal sinus. Now, I first heard about it from my team of Rings in Tirana, and he's emphasized that a lot in his group. And so this is something that we thought, okay, let's, this is one of the possibilities here. Now, the interesting thing about this petrosal sinus is not only do we not see it on an angiogram, but it's also hypoplastic to begin with. Now, when you look at the bony anatomy, when you look at the bone, you can figure out from the bones if the sinus, used to be big or what. And it didn't look like it was any big to begin with. So you see a wisp of it here. Again, Dyna CT is key here. Like if you're gonna go for these like kinds of things, really, really want to understand where you need to go. And so I think this is your roadmap. You see like a little bit of a petrosal sinus. And so the bottom line is like what to do. Eitan really wanted to try this. To like his infinite credit, like this is like, instead of going, we wanted to do some other things, turns arterial. It's like, no, let's like really spend time, try to do this. And that's what happens. So we have like, this is our standard setup. This is just some technical stuff. I think this is either, I don't know what this is. This is some sort of 6 French guide, probably, it's either Neuromax or BMX or whatever. And then through that comes a 5 French vert, which is nicely directable. You can really stick that into the ostium of the inferior petrosal sinus or the opening of it, and provide like some good support for whatever you're going to use. So this is what we're doing, like pointing this way. Here's a microcatheter. Now we know where to go based on the Dyna. The Dyna lets you understand where the entrance to this thing is. And so this is how it goes. Like we go like this. This is like a frontal view. And so we're starting like now we're making some progress. There's a wire. I think this is a standard synchro. And the catheter is a headway duo. We particularly like it because it's a very low profile. So if you're going to go through something like this, we prefer to use a duo because I think it tracks very well over an 014 wire, but like especially like a standard or something that's a little bit more supportive. The tracking is excellent. So that's what happens. We get pretty close. Now, somehow we end up in this pocket. It's a little bit of like, search and destroy, so to speak, like you're getting into a pocket, you see where you are. So here we are like injecting and somehow we've opened up this connection. So probably what happens is, this is the reason we see the fistula from this pocket, even though we don't see it from the angiogram. It may be because it's just flow related thing, but probably it's not. Probably what's happening is that the sinus was occluded. It used to drain the fistula, and because of high flow venopathy, it got occluded. That's what often happens. That's how fistulas usually progress. They close off their venous outflows one by one until, you know, whichever remaining outflow exists defines the pathology. If the remaining outflow is towards the eye, and that gets occluded, then the eye starts to go. If the remaining outflow is towards the brain, and you know, that's not tolerated, then the brain suffers. And so that's what happens. But so in this case, I think what happened was that this got occluded. And so when we're like digging around with the wire a little bit, probing, huh? Gently, carefully probing. It's possible, by the way. So we're kind of in the back of the clivus. It's possible to put a hole in one of these things. If you do, you'll end up with like a little weird subdural. It's been done. Kind of got away with it. Usually the flow here is very, very little, right? This is an occluded sinus. So even though we see a connection to this fistula, flow there is minuscule. So I think it's a fairly safe thing to do. We use micro wires, like Timo advocates using like an 035, like a little bit heavier wire to probe the channel, which I think is just a matter of like experience, which one you feel more comfortable with. The disadvantage of our approach is, of course, you may not have enough support. But in this particular case, it worked out. So basically, we see this like little pocket. Now, we're not in the fistula. So if we're going to inject onyx from here, which I think is would be the choice of the embolic material. From the artery, I'd definitely use glue. But from here, I think you want to use onyx because you really want to like probably just like form a plug here and try to push as much as you can into your target. But it's not ideal, right? If the onyx, more or less, it's a crapshoot. It's either going to go or it's not going to go. If it doesn't go, we've shut off our avenue. So here, Eitan really decided that he was going to keep trying and try to get into that, into the fistula pocket itself, and it worked really nicely. Right here, you see the wire kind of going towards the pocket. Now, interestingly enough, it doesn't go through this channel. You see this channel is like more medially oriented, like say 2 o'clock. This wire is at 10 o'clock. To the spot. So it's yet another channel that was found. And so here we go. This is the lateral view, and here's the you know, the distal tip of the headway. Heading home. So right here it is. Now here's a video of the axis. Let me take a sip, huh? You see that? Here's our injection. There's the wire finding the way home. The catheter dropping. Right? There's a GIF, so we'll skip over that. And so here we are. Now the catheter is really in the fistula. It's in like it's directly in the heart of our fistula. Oh. Sorry. Okay, so we're basically in this channel, and so this is what we need to do. This is our target, and so exactly what we need to do is right here. Now, what happens is we go in. I'm not going to bore you with like how to coil, you know, a venous channel, but bottom line is it only takes a few coils. You see right here, there's like a horseshoe thing with coils. Like that, and that's what, well, it takes some coils and a little bit of time. As much as the fistulas are like really difficult sometimes to shut down from the artery side, they're supremely vulnerable when you get into the right place in the vein. If you're in that fistula's pouch of the vein, the stuff will die. Within a few coils, you wait a little bit, so many times the stuff is going to die. Now, some people are going to say, well, let's add more onyx, let's add some glue, whatever. I don't know. I probably wouldn't add onyx here because I don't know what the DMSO is going to do there. Probably nothing, but why bother? And I don't think you need glue either, because when you look at this picture, it's shut down. In our experience, once they're shut down like this from the venous side, they stay dead. And so now that brings us to another thing that Where is it? Let me see if we can see this here. Something that I really wanted to talk about. Give me a second. Okay, let's see. Oh, yes. I think it's right here. I had this whole thing set up, but there, yes. Okay, so this is basically, we have another case of emphasizes the same thing, and we just keep harping on this point because it's so key in treatment of dural fistulas, is that you have to find that common channel where everything drains. Oftentimes, there's only one place where everything is draining. You shut that down, and it's dead. You don't have to pack the whole cavernous sinus off. Now, you have to be careful. You don't want to paint yourself in the corner if you don't really understand the channel. But if you do, it's worse like a super selective embolization. It's really, it's this. It's the Achilles heel. That's where the thing is vulnerable. That's where you kill it. There's another case. But the reason I wanted to point out on this page is to give a shout out to Professor Kyushui and this notion, this idea of these like venous pouches that he has been like, again, it's in the literature. You look up the venous pouches. Mostly talk about it first in the sigmoid sinus fistula, but also in the cavernous sinus fistulas. Him, Goetz, this like emphasize this also, like this stuff is really like very, very important. So you have to understand that there's a common collector, there's a common pouch. We've thought it was an artery for some time for sigmoid sinus ones. It's probably is like, I think it's more likely that there are venous channels in the sinus wall, but they are the target. That's where you kill it. And so I wanted to just show that. And again, this is an example of a super selective embolization that I can also go to another page and show you at the very end. Now, once we're done, of course, we do this. You have to do like so control from every place where the fistula was supplied. You have to go inject every like left, right side, make sure you don't see it from any side where you used to drain, where you used to see it. And of course, it's dead. And now, what do you see here? Here we're injecting the right common carotid artery. And you see in the venous phase, you now see the same veins. You see these veins that were opacified previously by the fistula. Now all of these like weird looking veins, they are the surface cortical veins that the fistula used to drain. Now that the fistula is dead, the brain can use them again. And so it's trying to do that. You can see that they're filling by the brain. There's some stagnation there. They're a little bit slow. Again, the point is, do we put a patient on heparin with this or we don't? We don't do that. We prefer not to put the patient on heparin because we don't want the fistula to reopen. And I've seen that once at least. But other people do. I think it's a matter of personal preference. Will these veins thrombose if you don't do it? Maybe yes, maybe no. But certainly the transmedullary drainage still exists. And so what most usually happens is that the brain just like starts using them, and you know, a few of them might thrombose, but most of them are going to be fine. Now, in case you're wondering, certainly we're talking about this fistula. We're not talking about spinal dural fistula. You close a big spinal dural fistula, you better put a patient on something good. Otherwise, the spinal veins are going to go down, and that's a disaster. So it's a different story. But in this, we don't do it. So now, at the very end, oh, this, by the way, we go back all the way to the bottom, right? We're almost done. And here's our little bibliography. You can see some cases here, some articles right here for your viewing pleasure. And so the case library page, we emphasize very much as well. because there's a ton of cases on it. And I think they're pretty good, some of them at least. And so here, right here is this page where I think you might have seen this before, where we talk about super selective embolization. That was a super selective embolization of a cavernous fistula. This is super selective embolization of sigmoid fistulas, which we've been harping on for a long time, because I think that's the way to go. It's a super selective transvenous embolization of these common collecting channels of these fistulas. And it basically accomplishes two things. It spares the sinus. Usually this kind of fistula, this kind of architecture is more commonly seen in lower grade fistulas, where the sinus is still pretty good. When higher grade happens, the sinus often gets destroyed and the outflow is messed up. So there it gets more complex, even though you still can use this approach and save the sinus. Sometimes that requires stenting the sinus after putting onyx or whatever into the fistula, but I think can preserve the sinus and take out the fistula. Sometimes that's necessary. Sometimes they really need that sinus, even though it's very diseased. They don't have another one or something else happened and they really need it. And then you're stuck with making sure that you have the cake and eat it too. And so this is it. Like you have this anatomy. You could do like venous sinus sacrifice, which is old, works well, usually safe, although when you don't have another sinus, bad idea. But again, sacrifices the sinus, the transarterial ones we talked about, all this transarterial embolization, and then the transvenous. This is the magic bullet. Just put a little bit here. And so this is it. This is like, we kind of emphasize it when we talk about these things, like, do you do it with a sledge? Do you do it with a stiletto? Like this or like this? And so this is what it comes down to. But most of the time, just carrying the stiletto is enough, and you stick it where it, where it hurts, and you can kill a big fistula with like a really like directed super selective embo without having to do something like this, which is more expensive, takes more time. It's probably less safe because you're gonna, God knows what you're gonna get into when you do this. The idea is to accomplish what you can do with this. Doesn't always work. Sometimes you need the hammer. Most of the time, you just need this little thing. And that's it. Now, finally, go back to this, and I want to end on this note that I think this notion, again, this like idea of seeing the world in a grain of sand. You've taken this one case and we've used this case to branch into, this can go on forever. We can talk about this forever. And it's not just like disordered thinking. We're not just like disorganizedly going place to place. It's just everything ties in together. You can see how in this one case is encapsulated of so much of our training and philosophy. And some, we didn't emphasize technique too much, but this is also technique. So everything, a little bit of everything is in here. Again, a tribute to Kim Nelson, who's like used this to teach me and a whole bunch of people how to think of neurointervention, how to think of vasculature, how to think of these diseases. And again, a shout out to Eitan. It's like really his genius and diagnostic and interventional work that's driving a lot of what we do. We're going to continue to do this. So this idea of seeing the world in a grain of sand is something that we're going to continue doing from time to time. And I think more importantly, we're going to emphasize this come the future. So the future is really this. We've done it. Bananas, as a lot of you know. Since you're here, you've probably been there. So at some point, we'll see how that goes, but we're looking forward to Banana, the in-person experience. We had one Banana course, and then what happened. And so we're still waiting to get back to that. And we want to get back to that, hopefully in 22. We'll keep you posted on that. But when we do get back to Banana, we would like to do just this, because I think if you take a case like this, just dissect the case in the session, there's tremendous amount of educational value and it sticks. I think a lot of this really sticks. You remember, and you use it as a guide. So I hope you enjoyed this. This was long on purpose because that's how I think there's no like getting around this. But in the end, I hope you enjoyed it. And of course, we're going to see you in our future bananas videos, maybe in bananas and hopefully in banana. Bye.